Excuse me, ladies and gentlemen. Thank you for your patience in holding. We now have your presenters in conference. Please be aware each of your lines is in a listen-only mode. You may submit your questions electronically anytime by using the chat pod located to the right of your webinar platform. You may also download a copy of today's slides using the Files pod located below the slide presentation. It is now my pleasure to turn the conference over to today's first presenter, Jen Braun.
Thanks, Todd. Hello, everyone. My name is Jen Braun, and I'm with the American Hospital Association and the AHA Team Training Program. I'd like to welcome you to the webinar, Reimagine Care Team Patient and Family Communication. A special thank you to our webinar sponsor, Vocera, for making this happen, and our case study from Hope Johnson from Lehigh Valley. So before I hand things off to Hope, I just wanted to go over a few housekeeping items. So as Todd mentioned, you can submit questions throughout the webinar using the Q&A pod to the right. If it's a technical question or anything we can answer in the moment, we will. If it's more content related, we will save it for the end. And I'd like to also add that we're joined by Matthew Kanegi from Vocera, who can also help answer questions as well. In terms of audio, the best way and the best connection to listen to audio is through your phone. So the dial-in instructions, if you'd like a stronger audio connection, can be found in the notes pod immediately below the slides. Finally, the webinar is being recorded, and we will notify all webinar registrants once the recording is available. So enough of me. I really want to get to the main event. I'm really excited to introduce Hope Johnson. She's an administrator of Peri-Op services at Lehigh Valley Health Network, so I'd like to turn it over to you, Hope.
Thanks, Jen. So like Jen said, my name is Hope Johnson, and I was really excited and happy to be sharing our story with you. Special thanks to Vocera, of course, for making it possible. And so, like Jen said, I'm the administrator of perioperative services at Lehigh Valley Health Network. Just to kind of talk to you a little bit briefly about our network, we're a complete health network with several varied campuses, most of which have ORs at them. And I am responsible for all of the clinical care, delivery, quality, staffing, financials for those perioperative services departments for 5 of our organization's campuses. We also have a variety of health centers and express cares, probably very similar to a lot of you out there. We do have our own physician group, so a lot of our physicians are employed, but especially in the OR, there still are a couple of key groups that are not, so that plays into this presentation as well. But one of the things that I want to stress, and I don't put this slide up to deter people, but it's to say that it doesn't matter if you are a health network of 10 different freestanding hospitals, or you are one freestanding hospital in the middle of a rural area and have 20 beds. You can still put this technology in and utilize technology to help just keep your patients informed and the families informed. So this is kind of for everybody. It's not just for those larger institutions. Here's just some of our achievements, obviously from a nursing standpoint, understanding that we're magnet recognized 5 times over, which is fantastic, so we are very proud of that. But you can just see the other various network achievements that we have. So today I'm going to be talking to you all about our kind of journey with putting in a system called EASE. It is by Vocera. At the time it was an independent company, but I've not noticed a difference at all. And really understanding what our journey was with the technology and how we're doing today with it. And then we can entertain any questions that you all may have. So the story kind of begins back in 2017. When we were approached by some of our C-suite level team members, and one of them had a personal kind of experience with a loved one that lived far away, and they were getting having surgery, and being that he and his wife were both the medical team members in the family, they were obviously getting messages about their loved one's care. And so when we were approached, the question quickly became, oh, do we do this here? And the answer was, no, we don't. So when people have surgery, probably like most of you all out there, they have their surgery. Some people have big boards that kind of give you an anonymity, and you can kind of see where they are in the process. Some teams have patient liaisons, which go back and forth from the operating room to the waiting room. But for us, we kind of did it the old-fashioned way. Patients and their families sat in a waiting room, or the family sat in the waiting room and waited for that physician to come out and say, all right, the procedure is over, and here's what we did. And hopefully they could find them. If they weren't in the waiting room, we would call a phone number, and that was about it. That kind of, obviously was the way that we always did it, but it was definitely a very antiquated way. And so to understand that we wanted to put a lot more into our patient and family communication, which also drives satisfaction, we were kind of given the go-ahead to get a technology in that could help us achieve that goal of increased communication, increase that kind of open and honest, visibility to the team and to their families, and kind of go from there. So our journey began. So really it's about selecting the right technology. As I said, there's a lot of things out there, and there are a lot of ways that you can do things. We are an Epic organization, so obviously, how can your EMR help or play into that? There's freestanding technologies like Ease, and really, what we wanted to do was kind of give everybody a fair shake. So I teamed up with a partner from our technology side of things, Information Services it was called then. So we had the technology side and we had the clinical side. And what we did was we looked at different vendors and got it down to 2 vendors. At the time, Epic did not have any kind of notification systems, so we looked at 2 separate companies. One was very passive, so really connected to our EMR, used the milestones that nurses were already documenting, and the other system was active. We took a big group of people, obviously knowing that it's more than just the clinical teams and the tech teams. We had a multidisciplinary group of probably close to 50 people that both got to see demonstrations of the technology. And we actually had a score sheet so that we could have kind of a weighted idea of what was the feedback from both of the presentations. And so there were physicians in the audience, there were nurses, there were technical people from technology, there were risk managers because that's a big part of it. So we all sat and we kind of were looking at this, both of these technologies. So when we kind of tallied up all of the evaluations, we really saw that the scores were pretty close. And at the end of the day, we kind of said, all right, well, what is going to tip this over? What's the decision making? And really for us, it was about matching the technology to the culture that we wanted to instill, from our organization. And for us, it's really about personalizing their care and making sure that patients know they're not just a milestone, they're not just a medical record number, that they're a person. And so we chose to go with the active solution, which is EASE, which stands for Electronic Access to Surgical Events, which makes sense because that's what we're doing. We're electronically updating families on where their patient or where their family is in their procedural timeline. So what we did was we said, all right, let's go with this active result, despite the fact that it is going to be work on the nurse's part, and we can kind of go from there. So we started by creating this messaging system. And like I said, when we really kind of had our risk managers involved, because of course, anytime you're sending information out about surgical procedures or anything for that matter where there's HIPAA involved, risk management gets to be concerned, which is understandable, right? Their job is to make sure that we mitigate risk in the hospitals. So when we talked to them, you know, they really were wanting to understand how the technology works. It is all HIPAA compliant, which is great. Everything is driven by the patient, which is great. So what happens is the patients are offered this service the day before surgery, sometimes even before that, because we do have pamphlets in waiting rooms of certain physician groups. They download the app on their phone. They invite anyone in their contacts that they would want to get messages. So I can't stress enough that this is all from the patient and the patient's standpoint. We aren't typing in or doing anything on the hospital side. So there's no, you know, concern for transposition of numbers and a phone number or something like that. So the patients invite their guests, and once they're registered on the hospital side of things, a message is pushed out to them that says, hey, Hope wants to share updates to her surgical procedure with you. If you would like to get them, please download this app. And then it connects the two via a QR code. So that's basically how the system works, and we'll kind of talk a little bit about how we rolled out this technology. So we took that group that we had that picked the technology, and we kind of made a smaller mini group that's a little more, we could control it a little bit better. We worked with the company, and Matthew, who's also on the phone, knows he was on a call with us every week, every Friday. We created kind of a timeline of events. Now, we were, again, given the go-ahead to put something in, but we were also on a tight timeline, and I think most things at hospitals, when you have the approval and the support of your team members that are, whether they're at the C-suite level or the VP or senior VP level, things get to move, and that's great. And we had that with this. But we knew that we wanted to get it installed by the end of 2017. And by this time, it was probably July or August. So we knew that we had our work cut out for us. So we assembled this smaller team, again, still members from risk management, clinical team members from the OR, you know, leaders in those areas, technology, people, and technology is kind of split up into kind of applications and people that deal with the Wi-Fi. So there was people from each of those teams involved. And we kind of said, what is our timeline of events? We made a Gantt chart and said, what do we have to do to get this installed? So one of the first things that we did is we went on site visits, because I think you can understand a lot from how other people did it. You know, you don't want to make the same mistakes, and so you can avoid those kind of hiccups ahead of time by going and seeing how others do it. So we did get to visit 2 different organizations. After we visited the first one, I actually changed my tactic, being the clinical person, because I'm an OR nurse by background, and so I can have a tendency to be very OR-centric and thinking, oh, this is all about the operating room, when in actuality, a large part of the clinical work is done preoperatively. So after I went on that site visit, we definitely changed kind of our direction, and I added some team members that were from our preoperative process, and that really kind of helped get that, you know, rolling out. We also said, okay, how can we start this? Now, we decided to start at our acute care facilities, which were 24 ORs at one and 8 at the other. But we said, wow, if we roll this out to 32 different operating rooms, that's going to be a lot. So how about we just start with a group that we know is going to both adopt the technology, be super supportive, and maybe that we can have a little more control over. So what we decided to do was start with our robotics team. Obviously, robotic surgeons are not worried about technology. They embrace it, and they were very interested in kind of helping us along on this journey. The other great thing about it is where there's a robotic component, there's typically a laparoscopy or an open component to those surgeries as well. Not all of them do everything exclusively on the robot. So we knew that when it would come time to roll it out to the urology division, the fact that we had some of the urology surgeons on the robot using this technology, we felt that it would be an easier transition and we could sell it a little bit more, because we had docs that were part of that team that could also help support it with the open physicians, if you will. So what we did was we created, risk management really wanted us to create guide sheets. So while we're really interested in sharing with the family members every little piece of gory detail, that's not necessary and it may put us at risk. So what they wanted us to do was kind of create a guide sheet that told the nurses exactly what to type into the messages. And we could do that, and we could change that based off the surgical procedure. So the cool thing about Ease is not only does it send messages, just like you would type a text message to your husband, your wife, your kids, it also can take pictures, and it can also take videos. So the messages were good for our risk management team, but they also agreed, that we can send pictures as long as we're sending appropriate pictures for what our comfort level is. And that's the great thing. You can use all or some of what is offered with Ease, which is great. So you don't have to use everything if people are uncomfortable. So for robotics, we created a list of what we would say, and we do. We hit key milestones in those procedures, right? So everyone knows that the second someone leaves that preoperative area, it's like you're going into the unknown. So we like to tell our patient families, we do send them a welcome text when they get there and are registered. We then send them messages that say that they're in their loved one is in the OR. And we like to use names. So we'll always talk to our patients about what do you like to be called, right? So if your name is Christopher, but you'd like to be called Chris, we know that. And that's how we can address the messages. We also like to know who the messages are going to, because maybe your name is Christopher, but people call you Pop-Up, and most of your grandchildren are on these messages because they're hip with technology. Well, we would want to call him Pop-Up in the messages. So Pop-Up is in the operating room. We take pictures of the robot. We take pictures of, because most people would never see a surgical robot, we take pictures of the physician, and we will say, here's Dr. Smith, ready to start Pop-Up surgery. We'll say when surgery has started. We'll talk a little bit about how surgery is progressing throughout the care of the patient. We also talk about wanting to get anyone that is at the hospital back to the waiting room. So we may say, Dr. Smith is just finishing up. If you are on the hospital campus, please return to that waiting room where he will see you and can debrief you on the patient on pop-up surgery or whatever you would want to say. So we kind of keep a cadence going with the messages. It does send us a message, the nurses, a message at 30 minutes if they haven't sent anything, kind of just like a notification. Hey, you haven't sent anything in 30 minutes. Would you like to send something? As just a reminder. For those of you that have worked in an operating room, sometimes cases get long and you kind of forget about the phone sitting there, or the time goes so quickly that you don't know a half hour has passed without sending a message. So we like to understand that. In our situation, we do have the circulating nurses sending the messages, but obviously we've worked with our physicians in the various divisions to make sure that the things that we are saying, that they are comfortable with us providing that information. Let me think. That's all I want to say about that. So we started in robotics, and we kind of then rolled out as we went along. So we started in 2 of our hospitals and started in robots. About 4 weeks after that, we kind of worked through any kinks that we had. Then we went to the next group. The next group was really our cardiac surgeons, and they had some concerns going into it. And I was a cardiac nurse in the OR, so I completely understand that not everything goes the way that you have planned. Sometimes you need the family's input on something, if something is untoward. That's where we wanted to talk to the docs about how this technology could actually help. So what happens in the OR is going to happen. Right now, before we had Ease, what we had to do was actually have the PAs go out and find families if there was something that happened. Well, with Ease, we could actually say, hey, the doctor is ready to speak to the family. Can you come back out to the waiting room? Families that haven't gone through this before really have no kind of semblance of what's the norm and what's abnormal. Even with cardiac, you don't even start the operation for an hour before the patient goes back anyway. So really, that time to the family that isn't in there every day is kind of just lost. So the fact that we could actually, if something did happen that was untoward, get them back, get the answers that we needed quickly without scaring the families, I think that was better. And I think that's what the cardiac surgeons ultimately saw, that this was just helping with communication and helping for them to be more visible to the patients and without being visible. And I think they really kind of took to that, and they actually turned this around quite quickly, and I will talk about that a little bit later. So they quickly became believers in the technology. Then we went on to our neurosurgical colleagues. Again, brain tumor surgery can be really scary, and I think for families that don't know if something's going to take 2 hours or 6 hours, it adds to that. So having this type of technology to support surgeries progressing, you know, the doctor, we're still working, is a really good message that you can give to a family versus just somebody waiting in a waiting room. So once we kind of rolled out to neuro, then we said, okay, by this time we're 3 months into the technology, let's go big bang and do all of the others at these 2 campuses. So that's exactly what we did. And then kind of at that 6-month mark, we looked at what about our other campuses. So we had an orthopedic specialty hospital. Let's go there. We had some other rural facilities that were farther away that we deployed in. So now it's kind of becoming second nature. If we merge with another organization, which we have done, we bring them up on the technology, just like we bring them up on Epic. When we build new facilities, which we just opened up a place in July, a brand new hospital, we put the technology in right away. It was part of the natural progression of the build. So as technology has all of their equipment, they have these the ease devices down. And then when we open other facilities, it's just part of that. So educating patients, families, and the care teams, I think, was really important because we wanted to let our patients know this is safe, it's free, and it's something that they have access to that sets Lehigh apart from other places. We're going to be with you every step of the way and keeping your families and loved ones updated to whomever you choose for us to do that. And as well as the care teams, to let them understand what the technology is really all about and how we can, adopt it. So policies and procedures are really important when it comes to these things, and I think risk management will agree that we have to have some guidance with this entire install. So part of our process, that Gantt chart that we did from the beginning and had weekly meetings on, was, okay, what about the policies and procedures? So at our organization, one of the things we did was we created a consent form. It is just a consent for communication, so it isn't a consent that has to get validated by a clinical or licensed team member. We actually have our administrative partner, or some people call them unit clerks, or the secretaries in the units. Ours actually goes and gets this consent from the patients. So like I said, we talk to the patients the night before. We tell them we offer this service, and if they would like it, we do check with them the next day. We target surgical procedures that are an hour or greater, and it's just for more of an ease of, no pun intended, for the nurses. If you're doing a BMT, you're not going to have time to be sending messages because putting tubes in a child's ears literally takes a couple minutes. So you're working on your documentation, let alone telling the parents that everything went fine. So we do kind of start with that. And we go in, we ask if they would like it. If they do, the administrative partner gets that consent that we are just sending the messages to the people that they chose. And then she takes her device. At Lehigh, we use iPod Touches, but that's actually transitioning more towards iPhones. And we do exactly what you see on the screen now. We take a picture of their bracelet, and we take a picture of the sticker that they have on their consent form, which also has a barcode on it, and then we take a picture of their QR code from the patient's own personal cell phone. Again, this is driven by the patient, so they are putting the app on their phone, inviting their contacts, and then they get a QR code from Ease. We sign that scan that QR code, and along with scanning the bracelet and the barcode on the consent form, it marries all 3 of those together so that we know that when we scan this patient's bracelet, it's connecting and sending messages out to everybody that they wanted on that QR code. And so she sends that welcome message, and then when the operating room nurse comes over, we have little tags hanging outside the pre-op room. So if any patient is an ease patient, we have the tag hanging outside their door. We also have it on a board where we have kind of patient information for the nurses so that they can check there as well. And that's kind of how they scan and go. We have brochures in our kind of some of those areas, like the heart surgeon's office, where we know that procedures are going to be longer. Our gynecology, oncology office, again, pretty heavy presence in the operating room, and we know that those are going to be longer than an hour, so we do have them there. Neurosurgery, orthopedics, so we do have the brochures over there. One of the big things that we educate patients on, which even I need education on every once in a while, is my Apple password, because if they don't know their passwords, they can't obviously download the app. And so I think a couple times, we've had our AP on the phone to kind of help reset passwords, because some of our, older patients may not know that. They do need to have a smartphone. So, flip phones won't work, although they are a thing of the past, although I think they're coming back. But, if they didn't have that, they could use somebody in their family. So if, one of our older patients didn't have a smartphone, but their daughter did, we could actually use her phone the patient would still register on that device, invite the contacts, and we could use that. If people don't have one and they still want one, we can offer up, and we have in the past, offered up some of our extra devices. They only can go to one phone, so obviously there's not contacts for a family member on a hospital-issued device, but at least it allows that patient's family to not be tied to the waiting room, because I think that's a huge goal. Waiting rooms can be depressing and dark. You feel like you're tied to them, and that's definitely not what we want at our organization, for our families to feel like they have to be tied down somewhere. We want you to visit our healing gardens. We want you to visit our cafeteria. We want you to feel comfortable. We want you to be able to go home if you live close and not feel like you're going to miss something. And so I think that's exactly what this type of technology does, is it really frees the families. Not to mention, if you've ever been on this side of the fence and sitting in a waiting room waiting for a loved one to come out, you're usually the punching bag with all of the responses from the sister, from the neighbor, from the cousin, from the son, from the mother-in-law, to say, well, did you hear anything yet? Did you hear anything yet? And obviously now you can say, everybody's going to get the same message. You have no more information or less information than I do. So I think that's also a great selling feature for patients and families, to be the ones to kind of get that out of their hands. It doesn't replace face-to-face conversations, and that's one of the things that we shared with our care teams when we educated them to this technology. That's great that we have this. It's an adjunct to that communication. So our expectation is still that the physicians go out to the waiting room, they talk to the family members that are there, or they call the family members that we have listed in the medical record as the point of contact. So it is, again, just kind of adding to the communication. If there are language concerns or language barriers, as some of our areas have a higher or more dense Hispanic population where Spanish is the primary language, we can absolutely have that go in different languages. I think EASE has something like 9 or 11 different languages that they can translate into. There are messages within the system that are canned, but if you don't want to make them up yourselves. But like I said, Lehigh made up guide sheets based on the type of surgery. So we send different messages for cardiac procedures than we do in robotic procedures. And we have joined with EASE to help make those in various languages as well, so that we're still have the integrity of the message that we want to send as Lehigh Valley, but they are in the patient's native or preferred language. So really, I think this technology is about helping to make an impact on the patients and family members, that we as an organization are transparent. We are dedicated to giving you information, not hiding information from you. And so I think, one of the big things that we see is the feedback from the patients and their families. So while you're going through and sending messages, once you kind of close out that message kind of section, so we close out the OR, we can give the patients and families a survey about, using ease. It's a Likert scale, and they're asked 5 simple questions. Questions like, would you recommend this hospital to others? Does the use of this technology show dedication to transparency on part of the organization? And we kind of use those as a gauge of how well we're doing. And they're a 10-point scale, so you can kind of see scores, and we'll go over those in a little bit. But also that you have free-form comments that family members can send directly to the nurse that was sending those messages. So the nurses all log into the system, and once you log in and you scan the bracelet, that's how you're connected to them, and it's under that nurse's login. And so if a family member gives back some comments, the nurse's phone will actually light up in the corner, and there's a little button they can press, and they can look at all of the comments. And the great thing is that not only does this make an impact for the patients and family members, us actually giving the messages, but it actually makes an impact to the nurses as well. And as I said, I was an OR nurse for a long time, and not that you're doing it for any recognition whatsoever, but we are probably one of the more forgettable nurses that people encounter in their hospital journey, just because of drugs like Versed. People don't remember us. We don't get gift baskets and fruit and cookies. But to see that they actually know who we are and appreciate the messages we're sending by sending us free-form comments like, this is the best technology ever, thank you so much to the nurse. Nurse Hope sent great messages during my dad's surgery. That's like really meaningful to the nurses that work with me. And so I think, that's a wonderful thing and a great thing that keeps the nurses engaged in sending the messages. And I think they understand if we do miss something, maybe somebody wanted it but we didn't give it, or the Wi-Fi connection was off. We can then go back and share that with the nurses, and they get quite upset if they have missed something. Or we can go back and give them feedback if they weren't providing messages when they should have been, and talk to them about how impactful this is to them. One of the best stories that I've heard, as I said at the beginning, we do like to understand who are we sending messages to today so that we can tailor our messages better to that person. And we had a patient that came in, and she was having a gyne procedure, I believe, and we said, so who are we sending messages to today? And she said, my son is deployed, he's in Afghanistan, and he's getting the messages. And I think for us, obviously with everything that's going on in the world today, and you say to yourself, wow, this is really why we do this. In yesteryear, the way that we used to do it, he already has a tough enough job doing what he's doing, where he's doing it, and now to worry about his mom just adds to that unnecessarily when there's something out there that can actually help and connect families, whether they live in California or are deployed in the Middle East. They can still get the messages and feel connected to their loved ones. So I think that was really definitely impactful for us. So we send messages, and we can get emojis back, which are amazing. So this was a feature that we got, and I think almost like one of the first quarters that we did this, or maybe we were only a couple months in when we got this. So this is pretty much one-way communication. I like to say it's 1.5-way communication. Nurses will not get messages back from families. So some people ask, oh my God, are you worried that the nurses are going to get bogged down with a lot of questions that they can't answer? Well, the system doesn't work like that. It is totally where we send the messages, and the only thing the family members can send back are those 3 emojis that you see, the thumbs up, the heart, and the long-standing. Is that a clap or is that a praying hands? We don't really know. So whatever it is, those are the 3 that we get back. The other thing that's really neat that EASE does for us is provides us with maps of where have we reached far and wide to people using EASE. So we would get a daily count or a monthly count of the states that we have reached through EASE. So obviously when people are inviting their contacts, they're inviting area codes to those contacts that are connected to states. And it became almost like a little bit of a fun game between my boss and I, and he's like, are you going to get to 50 states this year? And so it was really neat that we could get to different states. We also could get to different countries, Puerto Rico and the Dominican Republic. So it was really neat that we could see other things. And obviously knowing that we were sending messages to people that lived in Egypt or people that lived in or that were in the Middle East was really neat for people that were kind of away but still had, American cell phones. So we also could kind of keep track of how the messages that we were sending, and obviously as we got more refined and bigger and kind of expanded, we sent more messages. So this is always good because I think data is pretty powerful, and it's also what helps keep our teams involved. So again, some of those questions we would recommend hospitals to other, we demonstrate compassion and caring. We keep track of those and obviously want to be in the 90th percentile with those percentages, and we can keep track of that. And the great thing about EASE is that the teams there provide us with feedback based on all of those units. So remember I said we have this in several different hospitals. Well, I get really interested in how's my level 1 trauma center doing with this versus maybe my community hospital or our ambulatory surgical facility. And I think it helps me as a leader kind of put goals towards people, performance goals for both the directors and the managers at those campuses, as well as the staff. Hey guys, how can we increase our patient satisfaction? If that's the blanket goal, we can use different parts of that to say, how about we use EASE more? I want us to increase our EASE use by 50% or 10%. Or let's see if we can get a goal of 97% on would recommend this hospital to others on the EASE surveys. So I think you can use this to help support your teams and provide them with a really cool kind of goal in mind, and that they're included in that. So I'd be amiss if I didn't talk about how COVID really affected our use of EASE. And actually, I think people would think, wow, people were decreasing surgery, people were closing campuses, and we did that too, just like anyone else in America did when this first hit. But when we started to open back up, EASE was such a huge part of our reopening plan that I think it really helped us. So on campuses that we were keeping COVID-free, places that didn't have an ED, but we wanted people to have surgery and open that surgery up, we could say that we're not going to have anyone come in with you, right? We told visitors you're not allowed to come. And that can be really, really difficult to tell a patient, hey, I know your mom's coming in for heart surgery, but you can't come either, or you can't come with her. So what we could do is on that back end of that bad message is provide hope and say, but we have a solution for you that's going to keep you connected every step of the way, and that was EASE. So I think for us, we've really capitalized on having the technology during COVID so that we could, kind of just keep the families connected, which is what we wanted. So after we did the OR, remember I told you those cardiac surgeons that were a little, they were less than thrilled at first when I approached them about it. Well, probably, I don't know, we were probably a year into the technology, maybe a little less. And one of our cardiac surgeons came up to me and says, I know that at first we weren't really into this, but I really think that we should use this in open heart. And I said, talk to me a little bit more about that. He's like, well, there's a lot of milestones that we reach in open heart. The first 48 hours after open heart surgery, you're getting extubated, you're having, pacing wires pulled, you're sitting up in a chair, and there's such a stigma that still revolves around heart surgery. It's really scary for people. So he's like, why can't we use this? It also may cut down on some of the phone calls that the open heart nurses are getting because, Hope, I know they're getting so many throughout the day. Did my dad sit up yet? Is he eating? And, we get calls from everywhere. So what if we used it there? And I said, that's a really good idea. So what we started to do is we looked at, could we kind of continue this technology on, continue the session, if you will, on? And we could. So we worked with EASE to get our open heart nurses and our neuroscience intensive care unit nurses up on EASE and kind of sat down, same process. Let's look at guide sheets. What are some messages that we can send? And we did that. And so we rolled that out to open heart and neuroscience. Then we said, well, why aren't we using this in PACU? Because one of the things that we struggle with in PACU is PACU holds, right? So bed capacity, I think, is an issue across the country as well. Maybe a patient had a total joint replacement and we want them to get back up to the floor, but they don't have a bed yet because somebody isn't discharged. Well, the family member doesn't want to hang and wait around, especially with COVID. We're not allowing them to do that. So when they come back to the hospital, they often don't know where their family member is. So can we use this to both talk about their post-operative course and recovery room, as well as provide that information on, hey, we're going up to the floor now. Your, dad is going to be in room 301. And so we can kind of project that onto them. So if they did have to go, hey, I have to go get the kids off the bus, I have to go cook dinner, but I'm going to come back later, they don't have to stop and kind of wonder where their family member is. They already have that information. So after we did PACU and some of the intensive care units, we said, well, what about our procedural areas? Like, why aren't we using this? There are some EP procedures that are really long. Some of our cath procedures, really long. Interventional radiology, right? So we worked with those groups as well to kind of put that out there and get that out to people and are using it for those procedures. We started to talk about it for our labor and delivery colleagues, although at that point it was looking at, well, the baby's first picture is typically one that the families want to control and take over, and so let's let them do that and kind of revisit that at a later time. Same thing with med-surg. Could we pilot it on a unit where we're providing updates maybe once a shift or twice a shift or after our rounds? But again, with the pandemic happening and everything that's going on in the wide world of nursing right now, we haven't kind of gone down that rabbit hole, if you will. So, but I think always looking forward to making more meaningful connections using the technology. We did just open a brand new 120-bed ER, and we actually are using ease in the ER, a little bit more connected to the electronic medical record, where in the OR it's completely separate. And I don't have a whole lot of information on it because I wasn't part of that rollout, but I do know that EASE was always looking to kind of say, how else can we make our product better? And they definitely hit it out of the park with that one, and we were very anxious and willing participants to join in on that, especially understanding that communication in the ER is a lot of where all of your patient satisfaction surveys start stemming from. So I think that was important to know that we were keeping them updated and that they had what they needed. So I've been speaking for a while now, so I'm sorry I haven't looked at any of the questions, but I think they'll either ask me the questions or I can see some of them. And I have my contact information up there. It is like a little underscore, which sometimes are really hard. They don't come across. But I'm glad that one is you see that there. And I'm happy to take any questions that you have or talk about anything that might come up.
Awesome. Thanks, Hope. Really appreciate this in-depth case study. And I'll speak on a personal note. As a family member and caretaker, I think that this is incredible. I'll speak for myself that when we were in the waiting room, often felt very handcuffed and like we couldn't leave anywhere, always wanting an update. So this would have been a great solution to have. So thank you for sharing this. We'll do a bit of a moderated Q&A. We have about 15 minutes, and Matthew is also on the line. There were a couple questions which you kind of answered towards the end about other settings that this has been used in, so labor and delivery and other procedural areas such as CT and interventional radiology. So I wanted to give Matthew an opportunity to chime in to see if there's anything to add about where else this has been implemented.
Yeah, so I'm happy to chime in there. So in regards to the labor and delivery setting, so as Hope mentioned, oftentimes families love to take that initial photo of the baby and send to their family, but where we do see ease as a big success in labor and delivery is typically when emergency C-sections take place. In those times, then maybe all the family is not able to be present, and in fact, even the mother can't be with the baby when the baby is often then taken to the NICU. We've had many examples of where for the first few days where the mother was recovering, they were able to send videos and photos of the baby from the NICU to the mother and to the family because the mother is unable to go to the NICU after that surgery for the first couple of days. So I just wanted to add a little more to that question was asked, is that what we see with labor and delivery, it's not used for every delivery, but it hits in a really big, impactful way when used in those settings such as like an emergency C-section.
Thanks, Matthew. Moving on to another question is, so when does this technology and communication end? So specifically, Teresa was asking, can it be used to send discharge information to caregivers that can help them make the transition home easier?
I'm happy to chime in on that one too, and Hope, maybe you can start with just your perspective on that.
Yeah, I think for us we don't, and I think some of it could revolve around obviously different state departments of health have different rules. You know, we need to make sure that we can produce things that are discharge related in the medical records. And I think, you know, the more information that goes out, could there be more questions about it? I don't know. We do not, but I don't know if Matthew has other, you know, examples of where they have.
Yeah, so on that front, again, kind of depends on the technology systems you already have in place, right? If you are looking for a platform to do post-discharge information, that is current state something that we're currently working on to add to the EASE platform. So next year, that will be a feature that we'll have available in our product. It won't be in Q4 this year, though. It will be likely probably be about Q2 of next year that will then be able to start sending discharge and patient education information directly to the patient or to their primary contacts after they're discharged from the hospital.
Got it. Thanks to both. A question from Grace is, does the system offer different levels of contact? So for instance, primary contacts versus a larger secondary kind of tier of contacts, and can the messaging be changed or kind of distilled down that way?
Not that I know of.
I'm happy to, yeah, I'll help jump in there. So there's a couple different features within the EASE application. So Hope really did an excellent job of highlighting specifically it being used in the surgical setting. And in the surgical setting, again, the patient is selecting who is going to get all those updates while the surgery is taking place while they're under anesthesia. So all that's taken care of ahead of time, consented by the patient. But what we do is then in post-care settings when they might be in the ICU or if they're on the medical floor recovering, we also have video conferencing functionality that's actually built within the EASE app. For video conferencing, it allows the patient to select tiers of the contacts. So we did that intentionally for video conferencing because the patient may only want maybe their spouse to receive the phone call or the video call, and so that allows them to select so the clinician knows I'm going to initiate this video call with only the spouse or with their entire selected family by the patient. Again, all of that being selected by the patient, so that's not something that the nurse needs to worry about.
Thanks. Switching gears a little bit, this one might be more directed at Hope, but when you were initially rolling this out or when you brought this to different departments or units, what was the resistance from the surgeons and the nurses, or what were their concerns, and how did you address them, and maybe what were the differences between the two groups?
I think the surgeons' concerns, you know, mostly revolved around, well, what if something bad happens, right? And we're not sending a message that says, holy cow, they just hit the aorta, like somebody has to come and talk to you. You know, the nurses are not doing that. What they would say is, hey, the surgeon would like to speak to the family. If you're here, can you please return to the waiting room, right? Make it very generic and soft versus alarming. The staff, obviously the first thing they wanted to know is to make sure that they had time to do it, and I think, oh great, you're adding one more thing to us. And I think that quickly resolved itself when we said, listen, at the end of the day, your primary responsibility is always to the patient, and we actually tell them to tell the team member, or the families that as well, right? Hey, I'm Hope, I'm your OR nurse. I see that you have ease. Let me just send you a message so we can confirm it's working. I just want to let you know that obviously my first and foremost responsibility is to your dad, and I'm going to take care of him. If I don't send you a message, it doesn't mean that something's wrong. I could be focusing on him because I will always focus on him first and send a message second. Or there may just not be anything going on. So I think it's all about the upfront communication that you have with the family, because it's about meeting an expectation that they have, and if they know that expectation or can kind of level set that expectation from the beginning, that's great. And it kind of gives the nurse permission to ease up on. It's not like the second you roll in the door, you're picking up the phone and saying, we're in the room. You don't have to do that, right? They know. And that was one of the deterrents about going to a system that is completely fed off your EMR. So, right, as a nurse, I know sometimes you hit your closing and you're really not. Sometimes you've been in the room and you forgot to click it. So, and obviously we can, time that differently, but I didn't like that some of the stuff was driven from the medical record, so that's why we went with this kind of independent type of technology. But those were the big ones. And let me tell you that the second that our nurses started getting emojis and started getting positive comments, they came to us and were like, wow, we do this for the patients that come in the same day. How can we get this to the inpatients, right? So maybe you've been on the floor for 3 days because you had belly pain and now they're doing something to you. So we've tried to work out a process for that, because you have to remember patients have to have their phone when they come down because we have to be able to scan it, and the last thing you want is an inpatient bringing their cell phone down to the holding room to go into the operating room. So we've kind of worked on opportunities there with going up the night before and getting them registered, but that's obviously a work in progress. But that was driven by the nurses, and I think once they realized you're literally sending a message, people send texts all the time now. It's not that big of a deal.
Yeah, you're right. I think leveling expectations and making sure that everyone's on the same page is key. So that's a good tip. Kind of along those lines is, how did you all exactly determine the type of content and messaging, and how did you train the team to communicate like that? I know you mentioned that you, cohesively developed some guidelines and perhaps some template messaging, but if you could talk more about that.
Yeah, I mean, and again, shout out, kudos to risk managers and patient safety officers out there, because I think I'm really lucky that some of my risk managers and one of our administrator of patient safety actually was an OR nurse. So they totally got where we were coming from. But I think, again, their job is to mitigate risk, and they see it from a different lens, right? I want to tell everybody everything. Oh, my God, the tumor just came out. We just took out 6 inches of their colon and da-da-da-da, right? Where the risk managers are like, whoa, hold your horses. So I think what we did was just combined with them what would be key milestones. How do we put that in a term that is both not giving false hope, because obviously that was a concern, right? You don't want to say, the surgery went fantastic, everything's great, and then 2 minutes later they code, and the family's saying, well, what the heck? You told me everything was fine, and now, my loved one is passed away. So I think we're really kind of cautious, and so they kind of tempered what we wanted to say and put it in a way that was still meaningful, but not detrimental if something happened. And then we also kind of had to make it where it was recognizable to the layperson, right? So when you say, oh, okay, we're on bypass now in a heart procedure, people are like, what the heck does that even mean, right? That's a word we commonly use. Oh, they're on bypass, okay. When we say they're on the heart-lung machine, because most of the lay people know what that means, or at least kind of have heard of that. And so I think, or we've taken the tube out that helps them breathe, because that's a little, we've extubated them. People would be like, what does that mean? So I think working with them helped us. And the physicians, what do you want us to say? What don't you want us to say? Was also a help. And so how we train nurses is we have what we call guide sheets, and so there's every step, 1, 2, 3, 4, and it's messages in order of what they would send or how they could send them, to make sure that they're typing in kind of those exact phrases.
Got it. Thank you. And I know you mentioned that, there was a little bit of resistance from time to time from nursing, but have you come up with ways to incentivize them so there's more adoption? Or Matthew, you might know of other case examples from other institutions, but just wanted to flag that.
I mean, for us, it was, we posted, one of the things Ease provided us was, it's called OR Connector, and it was ended with OR instead of connector, and it was kind of just showed who was sending the most messages, so that was kind of just incentive, like, oh, look, I'm on the top, but obviously it goes a lot, in cases that maybe they do 2 or 3 or 4 a day and they're sending messages, they're obviously going to get 3 or 4 times as many messages as the cardiac nurse that's only in 1 case a day. So I think, that was kind of, lopsided based off what you were doing, but no, if there are, we get the reports of all the freeform comments every month, so I get reports at site-specific levels, so I can see how my ambulatory surgery unit's doing, how my PACU's doing, how whatever is doing, and we'll see the comments. And, if there's great ones that call out specific nurses, we can post that on our boards. But really, I haven't had to incentivize them because they know it's the right thing to do.
Yeah, that's great. That's wonderful. Thanks for sharing that. A question that I think we might end with this one is from Kim. So how long was the process from researching the product to actually having it live and available for use?
I mean, we went on a site visit in August of 2017, and we launched in December. So it was a pretty, for us, it was pretty quick for our organization. So I think we probably were doing presentations in July, figured it out, and, again, August site visit, I think August and September, and then we created, like I said, it was a Gantt chart that had, education, marketing, policy procedure, workflow, technology, so it had separate sections, and we had owners associated with them, and Matthew can attest, he was on the call with us every week, every Friday we had a call, and everybody had, like, okay guys, we have, 8 weeks left, where is everybody at with their to-do list? So it worked out really, really well.
And one thing to add to what Hope said there that helps is that this product's been in use for about 7 or 8 years now at many health systems. So we have a lot of learnings from that our team, when we implement, will help. Here's recommended phrases. Here's recommended clinical workflows. And our system is built to be, it's cloud-based, so it's off-premise from the hospital, so we can go live with it as a technology very quickly. And that enables the installation to really be very customized to whatever your all's timeline needs to be, but there's not a lot of technical work that needs to be done by your IT department or from our side, and that helps move things along faster.
Yeah, music to everyone's ears, right? That's great. Well, we're at near the end of the time at the top of the hour, so I just want to close for today and thank both Sarah and Matthew for speaking, and especially Hope for your presentation and all the work you've done. It's really interesting and really great stuff that you're doing, so we appreciate you and taking the time, and just wanted to remind all of our registrants and attendees that this is being recorded, and we'll be sharing the recording with everyone, so that will be available to you soon. So with that, thank you again, and enjoy the rest of your day.
This concludes today's webinar. Thank you for your participation. You may disconnect your phone lines, log off the webinar, and have a great day.